Uh, Good morning, my dear students and respected all other listeners. Today we are going to start with the second lecture of the topic of that strabismus. So be with me. So strabismus, today we are going to deal with the normal binocular single vision and the classification. That is the today's topic. Okay, so few words to understand the strabismus and the classification. We should understand what is mean by binocular single vision. Yesterday I have already told you that the two eyes we are having. So right eye obviously see more of right sided objects and the left eye will see or view more left sided objects. However, the whole scenario is visible. At the patient will not know that okay, I am seeing from this right eye, I am seeing this from left eye. No. So this overlapping of the images and the person will feel that yes, this is my single vision, single object I am viewing with my both eyes. That is the idea in anybody's mind. Okay, so binocular single vision, this is the simple terminology I have already told. Now coming to the definition, so more difficult words and difficult things, but if you understand the basic things, it will be very easy for you to understand this definition. When a normal individual fixes his visual attention on an object of regard, the image is formed on the fovea of both the eyes separately. That's why I have told you that right will be more visible in right eye and left side will be more visible from the left eye. Still, individual perceives a single image which is called as binocular single vision. So both eyes, dissimilar images are formed on the fovea. However, a person perceives a single vision and both eyes are involved, and that is why it is called as binocular single vision. Is that clear? Yes. So now we will go next. Here pictorial the implementation I am again giving you, that here you can see the central part which is visualized by the both eyes, but the right sided is only seen by the right eye, the animals, okay, and the tree which is on the left side, it is viewed more by the left eye because of the nasal bridge. Okay, so this component, however, the person is perceiving the image by the visual center in the occipital cortex, it works, and at the same time simultaneously person perceives that there is a tree, there is a home, the house is there, and there are animals, sun rising and all those things. Person will enjoy all this image with his both eye, which is simple language we are calling it as a binocular single vision, though dissimilar images on the two fovea of the two eyes. So here each eye maintaining separate image until visual pathways converge onto the visual cortex. This is a simple terminology you are supposed to remember. Here I have shown this cornea, eyeball, optic nerve, chiasma, then optic tract, then the radiations, and here is the visual cortex, occipital cortex. And what is the cream of this? So all the vision, okay, here the left sided vision, right sided vision, central vision, all is perceived here, it is getting combined, and here from the optic tract and the visual center in the occipital cortex, these pathways, visual pathways, they converge onto the visual cortex. Is that clear? Yes. And thus the binocular single image can be enjoyed by any person. Now visual development, few words about the visual development, because today's topic is classification of squint. Try to understand. First, because the binocular single vision is not there in squint. That is very basic thing. So you should understand the binocular single vision and its importance. Simultaneously, as you have already learned many things, means cataract, glaucoma, so they are congenital acquired types. Similarly, strabismus also related to the congenital acquired forms are there. So you should know this visual development. If there is any hampering in the visual development, how it can lead to the strabismus. So you should know first the normal development, visual development. That's why we are here to tell you that binocular single vision development. So binocular single vision is a conditioned reflex not present since birth. It is not present, and this binocular single vision is acquired during first 6 months, and it is means the start is there, but the fixed reflexes complete procedure occurs during first few years up to 2 years to 6 years. Important milestones in the visual development you should not forget, rather you should remember all time, is that at birth there is no central fixation and eyes move randomly, okay, and you might be going to see your some neonate baby or some relatives, so that time you can now see positively. At birth there is no central fixation, eyes move randomly, okay, and but first month baby starts taking the fixation. The spelling is wrong, I am sorry for that. So fixation reflex starts developing. 6 month becomes established, macular stereopsis is there, and accommodation fully developed. Now stereopsis, you must be knowing that 3D effect, and this macular stereopsis is achieved at the 6 months. Now at 6 years full visual acuity, you must be taking the visual acuity in your clinics at 6/6, 6/9 and all those things. So 6/6 is a normal visual acuity. That full visual acuity is attained and binocular single vision is well developed. So 6 years, that's why I have told you that 6 months to 6 years, easy to remember, and this visual development is going on. So this is a very, very crucial point in the life, and one has to be careful. If in this period only, suppose some problem occurs, cataract changes, traumatic cataract, or some inflammation like uveitis, last time we had dealt with the same topic. So if such things occurs, then the visual sensation will become lessened. So weak visual acuity will be there, and when there is a disparity between the two eyes, again there will not be the same perception from the two foveas to the visual cortex, and simultaneously there will not be a binocular single vision. That importance you should have. Now to develop this binocular single vision, prerequisites are there. Right now just few I have told you, but to be on the methodically, if we think, then one is the motor mechanism, another is the sensory mechanism, and third is the cortical process. So all these three mechanisms has to be perfect, then only the binocular single vision is possible. Now coming to the motor mechanism, means yesterday we have seen that in normal position, straight ahead position, straight eyes, parallel eyes, no deviation. So these requirements are necessary to have the binocular single vision. Suppose the motor mechanism is affected, suppose there is a paralysis of lateral rectus, the eye will deviate towards the medial side, it will not abduct. So it will go in the position of ESO deviation, okay, ESO inward deviation, that is called as ESO deviation. That time the one fovea of the normal, that is the left eye and the right eye, they will not have the same image because it will get deviated. The fovea will go away because the eye has come inward. So these things are very important. Motor mechanism has to be perfect, that's all. So to achieve the foveo-foveal fixation, this motor mechanism is very, very important. Again, the sensory mechanism, clear vision in both eyes to have the similar images on the both retina. So not only the same point, that fovea, but the same quality of image on the fovea is also required. Is that clear? So not only the position of the two fovea, image is forming on two foveas, okay, but what is the quality? Right eye is having 6 vision and left eye is having counting finger. Will it be the correlation? No way. So the sensory mechanism from the both eyes has to have not only the clear vision, but the magnitude, the quality of the vision and the quantity of the vision also has to be similar. Then only the binocular single vision will be there. Perfect binocular single vision, not some part of the binocular single vision I am talking. We will go later slowly to the grades of the binocular vision. Okay. Now coming to the third important mechanism, cortical process. So ability of visual cortex to promote for the binocular single vision. So two dissimilar images are there on the two fovea. Still there is a superimposition, fusional reaction, some occurs, and person perceives the huge view of one single binocular single vision image. Coming to the grades of binocular single vision, just now I have told you that slowly we will go. So this time we will go up. There are three grades actually. Binocular single vision is having three grades. What are they? One is the simultaneous perception, another is the fusion, and third one is the stereopsis. Now everything is focused immediately because this gives the differentiation. In simultaneous perception, what happens? You can see the first picture, or yeah. So this picture, what you are observing, that left eye is viewing the cage and the right eye a bird, and but at fusional and simultaneous perception means these slides are projecting from the machine called as synaptophore. Yesterday only I have introduced that word to you. So with synaptophore these slides are provided, and here the important thing you are supposed to remember, that from the left eye this cage is projected and from right eye person views the bird. However, if a person is having grade 1 binocular single vision, which is called as simultaneous perception, that person will feel that yes, that bird is in the cage, and you can grade that yes, this person is having simultaneous perception. That is the grade of binocular single vision. Now coming to the grade 2, that is called as fusion. That is the superimposition of two complete but similar images to form one complete image. Here in the synaptophore machine we are providing this slide. What is the slide? A rabbit with tail without a bouquet, and right eye is projected, again a rabbit with bouquet but without tail. However, if the person tells you that I am seeing a rabbit with tail and bouquet even, then the person is having grade 2 binocular single vision, which is called as the fusion. That means the person is superimposing. It is not the perceivance, it is not the simultaneous perception, but the two dissimilar, slightly dissimilar. So incomplete but similar, they are similar but they are incomplete rather. So this superimposition of the image occurs and person perceives that there is a rabbit in having tail and bouquet in the hand. Next is the stereopsis. In this PPT, I am sorry, I am unable to explain the 3D image. What they are showing, the buckets, two buckets, and from one side right sided view, left sided view, and this is the whole view 3D pictures. So you can remember few your 3D pictures, movies you can remember. Means literally you can feel that yes, it is happening in front of eyes. So this is the depth perception. Okay. So third component of the binocular single vision is called as the stereopsis. So what you should remember, there are three grades of binocular single vision. One is called as the simultaneous perception, it is the minimum. Second, higher level, that is the fusion, capacity of fusion. And third, normal individual having all the three, that is the stereopsis also, then the person is having perfect binocular single vision. Why this grading is there? If the person is having both eye 6/6 vision without any tropia, without any phoria, then the stereopsis can be possible. But if there is a dissimilarity, but not so much, means if a person is having 6/6 vision and 6/12 vision, so the fusion may get affected, 6/24 visions, fusion may get affected, but the person will have simultaneous perception. So some part or some grade of binocular single vision will be still maintained. Okay, and when this simultaneous perception is also not there, then the person is having only binocular single vision is not there, and person uses one eye at a time. If a person is having both eye some vision, then person may be using one eye at a time. That's all. Okay. I have already told you that best tested with the help of synaptophore, and this is the machine. You can see here. Right eye is viewing from the right side and left eye is viewing from the left sided tube, and the slides are we keep here the slides, and the projection goes here. Again the slides are kept here and the projection goes in the right eye, and whatever we are projecting, that already we have discussed. So we will go next. We should understand the normal retinal correspondence, because these are the terminology you should know whenever we are discussing the squint topic. In normal binocular single vision, there is normal retinal correspondence, and there is a precise physiological relationship between corresponding points of the two retina. Now what is corresponding point? Okay, here I will tell you that two fovea of the two eyes, they act as a corresponding point, and remaining is the reference. So fovea, the right sided fovea, left sided fovea, they are corresponding points. Now right sided fovea, okay, here temporal, posterior pole, this is the optical axis, this is the optical axis, primary position, parallel patient, normal patient we are discussing. So optical axis is here right eye, optical axis left eye, and these are two parallel things, there is no deviation here and there. Okay, so parallel. Fovea is away from the posterior pole, that is the, so temporal fovea is here, here is the temporal fovea. Okay, now whatever the object of regard is here, and it is coming, getting focused on the fovea. Okay, two eyes, here is the fovea, here is the fovea, and two eyes, object is here. So whatever the object is projected, patient is our normal patient, 6/6 vision, it is getting projected on this right fovea, this is focusing on the left fovea, and these being these two corresponding points. Okay, normal retinal correspondence we are discussing, these are corresponding points, so the image will be perceived as a one. Okay, so these are the corresponding points. Understood? Yeah. Now the temporal retina of the right eye and the nasal retina of the left eye, the points are corresponding. Suppose here is the fovea of right eye, there is a point here temporal, so RT1 is a point, suppose. So here left end 1, nasal 1. So these 2 points, they will be having the same value and they are called as a corresponding points. Similarly, 1, 2, 3, 4, 100 points, and this is one meridian again above that. So because it is a hollow, it is a cup shaped area you are supposed to visualize whenever we are discussing the retina. So some points will be in the same line, below also, above also, away. So now what I mean to say, so all the points which are temporal to the fovea of the right eye, they are corresponding to the nasal points on the retina of the left eye. Is that clear? So here is the projection. Once again I am showing you that points on the nasal retina of one eye have corresponding points on the temporal retina of other eye and vice versa. I hope you are now clear. Again we will see this same image, and you will get more clarity. An object producing image on the right nasal retina and the left temporal retina will be projected into right side of the visual space, and this is the basis of NRC, that is the normal retinal correspondence. Is that clear now? Yes. So now coming to our today's topic, one slide I am revising that definition of strabismus. It is the misalignment of the visual axis of two eyes, which is called as squint or strabismus. Remember this. So alignment of the visual axis is normal, parallel, that is routine process, but when there is a misalignment, then it is called as strabismus. So keep in this mind, so that we will go for the classification as per your UG syllabus. This is important. Pseudostrabismus. We have there are so many pseudos in ophthalmology. So pseudotosis hai, huh? So you have like that pseudostrabismus bhi hai. So that there are it is also called as apparent squint. When there is pseudo, there has to be true. So true strabismus. Again, it is manifested or not manifested. Not manifested means latent, hidden. So invisible, and manifest, visible. Even patient tells that this eye is deviating outward, this eye is deviating inward. So visible, patient can diagnose the condition. So it is tropia. It is also called as heterotropia, which is hidden. We are going to elicit. It is phoria, hidden. We have to search for this. We have to become police inspector and search for that thief. Heterophoria, which is invisible. Now this manifest squint or heterotropia is again divided into two types, that is the concomitant and incomitant. These two words are very fearing words to the students, but slowly you will understand everything. I will try my best to teach you, and this is the simple slide. You should you should fix this data in your brain, so that whenever a classification is asked in the examination, you can write down this simple classification, because this is a theoretical process and you are supposed to write. Now we will go into detail and clinical aspects of the strabismus. Considering the strabismus, again it is getting divided into various types, and those classification points also you should know. Okay. So we will go slowly. Strabismus classification. When we consider that classification, I am not telling that whatever the shown slide was wrong, but to be on the safer side, they say that classification is no perfect classification is there in strabismus. Only thing we can study or we can discuss the things according to, one, the fusional status. Fusional status. Now it is very easy for me to tell you that what is fusion, because you know, good students, just now we have learned that the binocular single vision, fusional capacity, है so grade 2 binocular single vision grade is there. So this fusional status, two images of the two eyes, fusional status is, if it is possible, good fusional status, good fusional control is there, then the strabismus will not get manifested. Okay, so patient will try to maintain the fusion of the two dissimilar images, and it is nothing but the phoria. It is the latent squint, it is the hidden squint. So is that clear now? So why the fusion is important? It helps the patient to get the binocular single vision, to control the phoria, and it will not allow to squint to become manifest. So this is the importance of the fusion. Suppose a person is a debilitated patient, fatigue phenomenon is occurring in the evening time, there is a weak control of the fusional control. So sometime there will be squint, sometime there won't be squint. So it is nothing but the intermittent tropia, because it is manifesting. It is not so sometimes it is phoria, hidden, but it is getting and converting into tropia, that is the manifesting, visible. So invisible जो है वो visible बनेगा. So phoria to tropia, that conversion is going on. So it is called as the intermittent tropia. Okay. Now the next third, you might have imagined which is not intermittent, constant phenomenon of the tropia. Zero fusional control is there, not present. Fusional reflexes, they are not at all helping the deviation to. So the person will have a constant tropia. It is a manifesting squint and it is a constant phenomenon. So whenever, depending upon the fusional status, there could be phoria, that is latent strabismus, or it is a invisible strabismus, good fusional control, intermittent tropia, partial fusional control, sometime it will be there, sometime it will not be there. सुबह तो नहीं रहता, बाद में वो धीरे धीरे फटीग हो जाता है और वो फोरिया gets converted into tropia, it becomes manifested and we call it as an intermittent tropia. So time relation will be there, or debility or fatigue phenomenon will be there. So tropia. Now tropia, it is a manifest squint, all time it will be there. So constant phenomenon and fusional reflex control is not at all present. Is that clear? We will go next. Type of deviation, very simple. If the eyeball is deviating in a horizontal plane, either it will be in exo deviation or out exo deviation. So the type of deviation in exo deviation, outward deviation, exo deviation, vertical up deviation, and there is no hypodeviation. Hypodeviation is a relative terminology because we consider that hyperdeviation only. Deviation, like that the terminology goes on. Third is the torsional, which is not for the UG level, but it is an encyclo or excyclo deviation. Okay, is that clear? Yeah. And it is not that the only thing that one the horizontal or vertical will be there, but it could be a combined thing also. Now this is very important thing. Variation in the strabismus or variation of deviation with the gaze position. Last lecture yesterday we have seen that what is the position of the gaze and fixating eye in relation to the fixating eye. So it has been divided into comitant or concomitant and again the incomitant or non-comitant. Now see, I'll tell you. I'll first read for you first. So the size of deviation not vary with the direction of gaze or the eye used, any eye used, right eye, left eye, for the fixation. Now what is the meaning of this? This is very important, and this level only I will try. This is the parallel position, no squint, but there is a squint. Here, one patient, exo deviation is there. What the slide has told you, that whatever the size of the deviation is there, it will remain constant in all gaze, right gaze, left gaze, up gaze and down gaze. So here this size of the deviation will not change according to the gaze. This is the meaning, and this is nothing but this is called as the comitancy or the concomitant squint, which is absent in incomitant, or incomitant squint is divided into paralytic squint or restrictive squint or orbital strabismus and all those things. We will come later on. But here the comitancy means the whatever the grade of the squinting position of the eye is there in primary position, same position will be there in all gazes. On cardinal positions, yesterday only we have discussed. So the gaze and the size of the squint or the magnitude of the squint, deviation of the squint will remain same in all gazes, and that is the meaning of the sentence what we have just now read. Now coming to the incomitant, it is now very easy that this will vary. This will vary in incomitant. So if this size of deviation vary with direction of gaze or the eye, that which is the fixating eye, means right eye is fixating, left eye is fixating, and still it is changing. So this could be paralytic or restrictive. I hope that this comitancy, or that is a concomitant squint and incomitant squint, this basic fundamentals has to be clear, and I hope I have tried my best. Now coming to the fourth point, that is the fixation. Fixation, according to the fixation, this is very easy to understand. Fixation means which eye is fixating. Either alternative, spontaneous alteration of fixation from one eye to other eye. पेशेंट को पता ही नहीं चलता कौन सा आई यूज कर रहा है. ओके, सो वन टाइम द पेशेंट विल यूज हिज राइट आई, अदर टाइम that person will use left eye. So this becomes alternating. It is embarrassing for the patient as far as the cosmesis is concerned. However, the patient is using for one eye for distance, other eye for near, and those deep things we will not go in detail, but alternatively patient will move the eye, rather not to move the eye, but so it is getting moved, means spontaneous. It is patient will not know which eye he is using and all those things. Sometimes he may, if he thinks, then he will know. If he thinks, he will know definitely. And next is the monocular, that is the preference for one eye to fix it. Now you are so clever that why the preference will be there, because of the good visual acuity, is it not so? Yeah, so I have already told you that alternative squint, whenever there is, these are basic principles or fundamentals. So visual acuity has to be equal, or little plus minus thing variation will be there. But monocular, yes, if you see a tropia by a person, what immediately you will see that eye is having less vision. From your chair also you can say that this is a affected eye, and what is the vision, unless proved it is a paralytic squint. Because in paralytic squint, how the paralysis occurs, one day the patient is normal, next day vascular some episode occurs, and the person will have a paralytic episode. Okay, and that time vision is already good, 6/6 vision in both eyes. So there is no relation of squint versus the vision in paralytic. So paralytic squint there will be good vision, but in concomitant squint I am telling you that non-paralytic squint, usually the motor the sensory phenomenon is hampered, that is the visual acuity, and that's why whenever there is a tropia and there is you are supposed to test the vision, and there has to be some correlation of less vision in the tropic eye. So this is the slide. I think we should go next slide. Age of the onset. Already we have discussed some congenital, some acquired problems, like in strabismus also it is there. Age of onset is very, very utmost important. We can label congenital strabismus whenever the strabismus is documented before 6 months, or then we can call it as a defect at birth. And usually the infirmant is mother deviation is occurring since birth, and or after 1 month or 2 months, still it is called as a congenital only. Acquired, yes, occur after normal visual development. That's what I try to tell you, that paralytic squint are occurring after the normal visual development. Suppose at the age of 40 the vision visually is 6/6 in both eyes. Okay, after 6 years again the if suppose some problem is there, traumatic palsy is there, then the person will have normal visual acuity in both eyes, and this strabismus can be manifested congenitally, or even it could be acquired. That's the thing. Now coming to the utmost important slide. Okay, etiological classification. You feel that this is a bore thing, madam, but this is a very good thing to understand and to write in the examination also. So first is the etiological classification. It could be primary, it could be and we are dealing with tropia only, not phoria. Phoria is a latent squint, it is hidden squint, and strabismus etiological classification abhi jo chal raha hai, that is primary, heterotropia, all are manifest squint. So manifest squint is divided into primary है तो सेकेंडरी भी होगा ही होगा. देन थर्ड वन इज द अकोमोडेटिव, फोर्थ इज द कॉन्जिक्यूटिव, पैरालिटिक, मैकेनिकल, दैट इज ऑल्सो कॉल्ड एज रेस्ट्रिक्टिव, एंड देन ऑर्बिटल स्ट्रैबिस्मस. दीज आर द जस्ट क्लिनिकल क्लासिफिकेशन, यू कैन से सिंपल क्लासिफिकेशन टू रिमेंबर. So we will go one by one, few lines about each, few lines, not bombarding so much of depth. Okay. Primary heterotropia. Tropia means manifest squint. Okay, so there, as the term is there, primary means no cause, no etiology. So primary heterotropia, without any known cause there is a strabismus which is manifested. Why? So Duan has given this, that convergence, it could be convergence, etc. If we are considering the EZO deviation, suppose EZO means inward deviation, it could be because of the converging capacity is more, and that's why the eye is deviated in, and this will more for the near. we measure the strabismus. We will go slowly. I will tell you later how to evaluate, how to examine the squint patient. That time you will know that near and distance, it is not the same thing. The squint changes. So here, if the person is having ESO deviation, convergent squint we call it as, so that can be more for the near than the distance if it is having a convergence excess. And if it is more for the distance, there has to be called as a divergence insufficiency. Okay, so distance divergence insufficiency. Similarly, exodeviation patient is there, then for near, if the exodeviation, deviation of eye is more, outward deviation is more when the patient is reading, then it is less convergence, and that's why eye is going out. So this is exodeviation because of the less convergence. So we will give the patient more converging exercises. That also we will go later on. Many people you might have seen your colleagues or friends or relatives, they are doing some pencil exercises at home also. So these things are not very far away from you. Now the divergence excess type, exodeviation, which will be more for the distance. So this is a little bit tricky, difficult you may feel, but it is slowly you can digest. Okay, so stay with me. Now the second type of this tropia is divided into accommodative. So accommodation and accommodative convergence. Okay, so here patient is accommodating for the near, but simultaneously the medial rectus also getting involved in this reflex, and if it is more convergence and because of the more accommodation, more convergence again. So the hypermetrop patient especially, they try to accommodate more and more to visualize the near objects clearly, and they get more convergence. So this accommodative phenomenon is also important. We have to find it out. Now coming to the secondary. Secondary means we know the cause. Usually it is also called as the sensory tropia. Naturally sensory means some stimulus is deprived, that is the some vision is less in one eye than the other, and that is called as anisometropia. You might have finished this all terminology in the refractive error classes. And macular pathology also. So macular pathology, if there is an organic lesion at the level of macula, the part will not function, and we know that fovea is a central part of that macula which is having 6:6 resolution. If this part gets affected, naturally the visual acuity resolution will get deteriorated, it will be less than the other eye, and that's why the sensory impulses will not be proper in both eyes, they will be dissimilar. So again leading to anisometropia, but it is not a refractive error, the dissimilar vision in the two eyes, and it is so only not the refractive error, but we have to see even the fundus also. We have to examine the patient as a thorough examination. So this secondary strabismus is important. Tropia, we are again I am telling you the manifest squint. Now next is the component is the consecutive. What it is? There was a squint in one patient, and he was very keen about the cosmesis, and he underwent the surgery, and the surgeon has done some overcorrection. Not done, it has happened, it can happen. Okay, so surgical overcorrection is there. So that, so अगर ESO है तो EXO बनेगा, EXO है तो ESO भी बनेगा. So that is a process called as a overcorrection. So here it is called as a consecutive tropia. Okay, so after the surgery, overcorrection, and then it is called as a consecutive tropia. Remember here at this level only, spontaneously a ESO deviation may go outward, that is called as the resting position of the eye, and this is possible that we will deal later, but at this moment we should not skip this. Next is the paralytic. Tropia is again another component is a paralytic. Yesterday I have told you that extraocular muscles we have dealt, 3rd, 4th, 6th cranial nerves, they are important as a nerve supply for the extraocular muscles. Okay, so if the 3rd nerve palsy is there, suppose for example 6th nerve lateral rectus जाएगा, 4th nerve superior oblique जाएगा, but ये 3rd nerve It is supplying all the extraocular muscles, that is the superior rectus, inferior rectus, medial rectus, inferior oblique. Okay, so all these muscles plus some intrinsic muscles also, like ciliary muscle, sphincter pupillae, levator palpebrae superioris, that is a lid muscle. So all these muscles also, they are getting supplied by this third nerve. So all extraocular muscle palsy, if it occurs, it is called as the external ophthalmoplegia, if the extraocular muscles are involved. If the intrinsic muscles are only affected, it is called as the internal ophthalmoplegia. And if both extrinsic and intrinsic palsy is there, it is also called as total ophthalmoplegia. So tropia, if there is a problem, then you are supposed to see which movements are affected. Okay, lateral deviation is possible, so it is not lateral rectus has acha hai, okay. Medial rectus, oh, it is not getting deviated medially on my command, so I will see the pupil, I will see the ptosis if it is present. Okay, this is the correlation. That's why we go clinically, and this classification is useful as far as the clinicians are concerned. Next is the mechanical or restrictive. Suppose you might have seen a person having proptosis, some thyroid ophthalmopathy is there, and muscles are abnormal. They are actually involving the muscle or the tendons, and it restricts the movement of the muscle. Even a fracture orbit, the orbital plate, floor of the orbit is fractured and the eyeball sinks down. So there will be a restriction for the inferior oblique, which is below muscle. So that type of things can happen, and there will be a mechanical restriction of because of the muscle. It is not the nerve affected. It is not the capacity of the motor mechanism, but it is the restriction because of the mechanical hampering is there, and that's why it is this tropia is called as mechanical or restrictive tropia. That spelling is wrong, I'm sorry for once again. So now the orbital strabismus. So orbital strabismus, because of the anomalies of the orbit in the form of craniofacial dystosis, there are so many and so forth. Hydrocephalus also will produce the orbital strabismus type of picture, but I will not go in that detail, and we should not also. This is UG class. Now coming, so once again, soothing for you people, that strabismus is divided into true and pseudo. Pseudo is apparent, also called as apparent, and true is called as latent. Divided into two: latent, heterophoria, or invisible. These words you should remember. Manifest, also called as tropia, it is visible. Again, it is divided into concomitant and incomitant. Now you must be knowing that, yes, here I will tell you, there is deviation, but the size of deviation remains in all gazes same. This is the committancy which is absent in the incomitant, and you can remember this slide. Now, yeah, this comitant squint as uniocular, convergent or divergent, alternating भी हो सकता है, that we have discussed. Okay. Coming to some funny pictures, I want to show you that some, otherwise it will become only a theoretical part. I will just show you, I will run through all the pictures. And pseudo strabismus, or it is also called as apparent squint. Here there is no true strabismus, pseudo. What is pseudo? Because the visual axes are parallel, there is no defect in the parallelism of the two eyes. However, some different thing here, the epicanthal fold is prominent, and it is giving the false sensation, that is the patient is having pseudotropia. Okay. Next, once again, here there is a hypertelorism. You can see the wide distance, and you can feel that patient is having pseudo exotropia. Exotropia lag to raha hai but nahi hai. Okay, so it is called as pseudo exotropia. Now coming to the heterophoria. Heterophoria, it is also called, we have discussed that latent strabismus, because latent by fusion. This is just a revision. When influence fusion was given, then that cover test is there. So all these investigative modalities. So orthophoria, what is orthophoria? It is the perfect alignment of two eyes which is maintained even after removal of influence of fusion. Can it be possible? in absence of any stimulus of fusion also, the orthophoria, perfect alignment. Actually, it is a fantasy, it is a physiological heterophoria, because practically small amount of heterophoria is a universal, and it is known as physiological heterophoria. Okay, every person will have, only the question of how much capacity of the fusional reserve is the person is having, and if it is good, then there won't be any manifest squint. So तंदुरुस्त रहना बहुत जरूरी है, और खुद का नहीं, ocular muscles. So esophoria, tendency to converge. Exophoria, tendency to diverge. Types of heterophoria, and just now I have told you that convergence excess type, divergence weak, and all those things. Okay, so this is usually good for your theory purpose, or you may write down. Already we have discussed. Just I'm running through the slides. So hyperphoria, again it is a tendency to deviate upward, and cyclophoria, tendency to rotate around the anteroposterior. Don't forget that anteroposterior axis whenever we are considering the cyclophoria. Yesterday we have discussed the things in details, so I will just run through. And here that cyclophoria, again showing my drawing, but remember that it helps in your exam. So this finishes today's topic. So here I would like to tell you that you may feel that yesterday's class was a little easy than the today's class, but this will go on because next lectures also will be there. And don't forget to revise the thing. Whatever the yesterday's topic you have we have discussed, today also you read it, and whatever the topic we have discussed today, again revise, so that it will be a very easy thing to understand the further lectures. And all the best for your study. Stay safe.
Correct.